You're listening to the Physio Matters podcast in association with Choose Health, and this is session 40. Welcome back to Physio Matters. I'm Jack Chew, and despite vicious April Fool's Day rumours, I will be hanging around for the foreseeable. We need to do a little bit of housekeeping because we managed to fool quite a few people, including some sort of partners and long-time supporters and patrons and all sorts of people that we managed to fool, which sort of backfires in a lot of ways. So here's the clarification that no, I won't be stepping down from Physio Matters anytime soon. Physio Matters team haven't done a deal to turn Physio Matters into a virtual university where podcasts are the predominant mechanism of teaching, although it's certainly feasible, isn't it? I think that's why we fooled many people. That fake project hasn't been fake funded by the CSP and Nuffield. That's also not true. Our clinical lead, Mark Reed, isn't retraining to be a sport and exercise medical doctor. I can't remember what else we lied about, but there's a few things that came out in and around that time which are happening though. We'll be relaunching Physio Natters. That will be mainly hosted on Facebook. We're going to be doing live streams rather than edited interviews with all your favourite characters, so you'll get visual and audio for Physio Natters. There's also our student focus group, student and early career professional focus group that you need to follow on Twitter and Facebook, especially if that fits your bill or you happen to have an interest in the development of our up-and-coming professionals in the industry, then make sure you follow them. They're creating some brilliant content, and they'll be pushing some live streams also onto their channel, hopefully in the foreseeable. So great group of people that we're working with there that are doing fantastic work, so please do follow them. There is also if you're interested, there's a few people, only a few might I add, that seem interested in my sort of thoughts and feelings on all things in the industry and wider. So anything that healthcare touches, I often find myself commenting on. I'm rather opinionated, as many of you will know, and therefore I'm going to be hosting a conversation between myself and various friends of mine in and out of the industry on controversial topics, and it's called Chewing It Over, and it's going to be the show where friends try to stay friends. And so we're going to talk out certain features that are often hot topics in which controversy is stoked, and the premise being that if a conversation can't be edgy and controversial and still amicable between friends, then we really are screwed. So that's our plan, and that again is on Facebook. So find us on Chewing It Over with Jack Chew on Facebook, and that'll be going on live streams through Facebook. And for the podcast purists, don't worry, I will probably push that out to iTunes when I get round to it, so you can get that in the usual way that you'd get this show and others. We've got an awful lot of stuff going on with Choose Health at the moment. Mark Reed is taking lead of a clinic that we're running now in Altrincham, Cheshire. So if you have any patients, I know we get a lot of listeners worldwide, but also the UK is the majority of what we see. Then if you have any patients that you want to refer to us, which often happens, we've got an influx of that, which is why Choose Health's operated as a second opinion consultancy company for a number of years now, where we'll go out to other people's clinics and to sports teams and facilities that are provided by the referrer or the patient. And more people have wanted to come to us, which is something that we've needed to therefore provide some space. So we're starting to open a few clinics across the country, and we've got a new one in Cheshire, in Altrincham. So if you have any patients in and around the region that you feel you want to refer into us and want our opinion on, then please do send them over. Get in touch on the Choose Health website. Another thing that's going on, we've got a couple of spaces available. Not a lot of people know that we do clinical mentoring, and the core team at Physio Matters and Choose Health do clinical mentoring for clients worldwide. So from new graduates to experienced professionals to students that we Skype on a monthly or fortnightly basis to talk over clinical topics. Sometimes it's body parts, sometimes it's concepts, sometimes it's sort of a basic evidence-based or complex evidence-based thinking sometimes. And we've had a couple of spaces that have opened up recently, mainly because the people we've been working with for the months and years past are now absolute geniuses, so they no longer need us. They are probably, we could learn more from them now than they can from us, so they've flown the nest. And instead we've got some spaces opened up, so please do get in touch. Inquiries at choosehealth.co.uk if you want to email, but also you can find us in our usual social media places, and if you'd rather grill us publicly. I'm already aware of the time, so I'll crack on, but wanted to give a quick thank you to everyone that's given feedback on the last episode. As you can imagine, incredibly personal to tell my story of what I've been going through with my back and leg problems recently, and so the feedback's been wonderful, and I really was touched by people reaching out and giving their thoughts on not just the episode but also on how I've been getting on, so thanks for that. So today's episode is on ankle instability with Eoin Delahunt. I introduced him in our conversation fairly thoroughly, so I won't linger too long. He's an Irish physio and researcher that we got pointed in the direction of by our aforementioned brilliant student group, Eoin Cunniffe, who is one of the team there. He suggested that we check out his stuff, and we were pleased when we did to find exactly the sort of guest we wanted to talk about ankles with. And so I hope you enjoy this conversation that I have. So I bring you Eoin Delahunt. Well, I'm delighted to be on the line with Eoin Delahunt. I hope I've pronounced that right. I might get an immediate correction. Who's going to talk to us today about all things ankle instability, both acute and chronic. And delighted to have Eoin on the show, because we've been meaning to cover ankles for a while, and we've been looking around into the marketplace of ideas, as we often do, to find people that are notorious for working on consensus, working in collaboration, as well as having their own hand in more specifics within that field. And Eoin ticks all of those boxes for us. We're also very fortunate to be leapfrogging from a BJSM podcast done with Eoin and Karim Khan very recently. So they beat us to the exclusive. But what it does is it gives us a 20-minute insight there that mainly on chronic ankle instability, but also covers some great ground. So we would immediately point you in the direction of that, because we're going to purposely not cover some of those things in detail and get into the nitty-gritty of what wasn't in that. So we will use that as a platform to then discuss other things. So while we hope to be thorough today, I immediately direct your eyes and ears to that and welcome Eoin. So first things first, could you just introduce yourself to the listeners, tell a little bit of your backstory before we delve into all things ankle?
Thank you very much, Jack. It's great to speak with you today, and thanks for this opportunity, and hopefully I can provide some information that will be useful to the listeners. So regarding my background, I studied physiotherapy as my undergraduate degree, came straight from what we call secondary school or high school. So started my undergraduate degree in 1999 and finished that as a 4-year honours degree in 2003. And then upon graduation, I was kind of in the fortunate situation whereby I had 2 offers. I had the offer of a job full-time in a sports medicine and sports physiotherapy clinic. And I also was in the fortunate position of being offered an academic scholarship to undertake a PhD on ankle joint instability. So kind of negotiated with my supervisor at the time, and we came to a decision where I'd be able to work 2.5 days clinically and then study and undertake research on the PhD the rest of the time. So finished PhD in 2006, took me 3 years. And then after completing that, I worked full-time clinically for a year in the sports medicine and sports physiotherapy clinic that I had been working in during my PhD. And then in 2007, the opportunity of a faculty position came up in UCD in the School of Physiotherapy and Performance Science, as it was called then, and was lucky enough to be appointed after an interview. At that time, I continued to work clinically 2 evenings per week, and did that up to around 2010, 2011. And at the moment, I'm an associate professor in the School of Public Health, Physiotherapy and Sports Science in University College Dublin, and mainly have the typical academic roles of teaching, administration and research.
Fantastic. So lovely and thorough through your career, but always founded in sport. Was that specifically athletes of various levels, or did you see some sort of Joe Blogs off the street, non-sporty customers too?
Yeah, so it was a private sports medicine and sports physiotherapy clinic, and we had contracts with a number of different athletic teams, but not specifically high-level athletes. So people playing amateur soccer, amateur tennis, would have been a large proportion of the patients that we would have seen through that clinic. Yeah.
Okay, lovely. And so, having read as much of your research as I can get my hands on, although not all of it, of course, because you are rather well published, well cited. But if I was to summarise, I think is it reasonable for me to say that it's mainly lower limb, certainly these days? And if I'm right, then do you mind explaining as to how that came about? Why that interest?
Yeah, definitely. So you're correct in that observation. It's actually quite interesting because my final year undergraduate thesis was looking at shoulder muscle activation and shoulder patterns of movement in people with shoulder pain. But then the opportunity came up to study for a PhD on the area of ankle joint instability. And I guess that kind of guided my direction in terms of concentrating on lower limb injuries, and also due to the fact of the demographic of patients that I would have seen when I was working clinically, mainly were people participating in field and court sports. And what I mean by court sports would be volleyball and basketball as opposed to badminton and tennis. So a large proportion of the injuries that I was seeing clinically were lower limb injuries. So it always then developed a large interest in proper rehabilitation and decisions regarding, return to sport. So that's how my interest in lower limb injuries developed and evolved, really.
And I think, it's only wise, isn't it, to be constantly nodding towards what's going on up the chain. Anyway, it would be strange for you to be looking at the ankle with any sort of blinkers on, so that seems a smart move. But as I say, we're going to, apart from to nod towards it when it's relevant, we will be talking in and around the ankle more specifically today. Before we get going then, with regards to the ins and outs of assessment, treatment and management, could you outline what you consider to be the appropriate definition of lateral ankle sprain and the subsequent instabilities that can follow?
Yeah, sure, absolutely. So in 2010, we published a paper in Medicine and Science in Sports and Exercise. And what we had done for that paper was we reviewed all the literature published to date in the area of lateral ankle sprain and chronic ankle instability. And we developed some what we call operational definitions regarding ankle instability and ankle sprain. And since then, they've been championed or endorsed by the executive committee of the International Ankle Consortium, which is kind of a collegial group of academics and clinicians who are interested in ankle joint injuries and best practice regarding treatment and rehabilitation and best practice regarding future research initiatives. So kind of the definition that we have of ankle sprain is, or in particular lateral ankle sprain, is an acute traumatic injury to the lateral ligament complex of the ankle joint. And this typically results as a result of excessive inversion and internal rotation of the foot. And it typically results in some initial deficits of function and is associated with some level of disability. So what we mean by that is it's characterized by for example, pain, decreased weight bearing, inability to walk properly. So that's what that group has championed as a definition of ankle sprain.
And your that particular work was cited within the consensus document that we'll make available to the listeners, of course, and highly recommended for them. It was cited within that as being the definition of choice. I'm completely comfortable with it. Is there any alternative definitions out there that or any pushback that you've had in and around that definition that are worth mentioning?
We've had no ill response to that, or no negative response to it. As you say, it's has been cited, and it is endorsed by this collegial group, which is made up of, international representatives from North America, from Europe, and from Australia.
No, and that's great, and that makes sense. I can't imagine that there wouldn't be necessarily a particularly valid pushback against it. It seems fairly sensible and straightforward. I just know that there are sometimes movements with regards to trying to water down or make diagnoses or definitions more ambiguous with regards to locations of symptoms and tissue-based diagnoses and things. So I'm glad that you've not had your work co-opted by that pushback too readily, which is promising. I think, at least for this conversation, it doesn't muddy the water too much. If we can, reading the consensus document as well as understanding this both clinically and from further reading, the importance of talking about these issues and coming to a sensible sort of gold standard on this is particularly important because of the societal burden of what lateral ankle sprain then leads to. Can we talk a little bit about prevalence? And I know that there's some data presented in your work and you're aware of the statistics on this. So can we, for our listeners, outline the importance of us managing these things well and are certainly better than we are now?
Yeah, absolutely. So former doc student of mine, Calva Doherty, published meta-analysis or systematic review and meta-analysis of prospective epidemiological studies looking at the incidence and prevalence of ankle sprain. That was published in Sports Medicine in 2014, and we found that field and court sports had the highest prevalence and incidence of lateral ankle sprains. And we also found that the incidence and prevalence was higher amongst children compared to adolescents and compared to adults, and also that females had a higher incidence and prevalence compared to their male matched counterparts. When it's quite interesting, and this is a point that I always try to highlight to my students, in particular undergraduate students and postgraduate students, is that epidemiological studies are quite important, and we need to be aware of the epidemiological research, particularly in the fields that we are dealing with on a regular basis. So, for example, if you're a physio working with water polo, there's no point in being an expert in ankle joint injuries. Whereas if you're working with an amateur soccer team or an Australian rules football team or a rugby team, it will be important to be a specialist or have a real good understanding and appreciation of the injuries that are likely to be most prevalent and have the highest incidence in that particular sport. So when we think about ankle sprains, we know in elite professional football, for example, from the UEFA injury or Champions League injury surveillance study, that ankle sprains are one of the big four injuries. So in terms of the epidemiology, the most prevalent injury is hamstrings, then followed by hip and groin injuries. And then we know that there's kind of an equal prevalence of or adductor injuries, hip and groin injuries, and ankle joint injuries. So, just to summarize, I guess any field or court sport is going to have a high prevalence and high incidence of ankle sprains. Now, obviously, some sports such as American football or lacrosse may have a higher proportion of medial ankle sprains or syndesmosis sprains compared to other sports such as soccer or hockey.
And from what I understand, that's part down to the alterations in the mechanism of injuries and the specifics of what's asked of an athlete's body in those circumstances. Yep. So we might as well just nod there for the moment, although we're not going to cover them in vast detail. What are the key variables the key differences then between the mechanisms of injuries and load demands on those particular sports that make syndesmosis injury, for example? Let's talk high ankle sprain versus lateral ankle sprain. What would be the key differences there?
So something that we're working on at the moment is looking at video analysis of different types of ankle joint injuries. And typically what we see for a lateral ankle sprain commonly occurs during the transition from non-weight bearing to a weight bearing situation. So mainly landing situations. So that may involve contact prior to landing or may not involve contact prior to landing, but kind of the key characteristic feature of the ankle sprain mechanism in that situation is a rapid inversion of the rear foot and a rapid internal rotation of the foot when someone makes contact with the ground. And actually, it's quite interesting that oftentimes when we look at the kinematics of these injuries, they're already contacting the ground in a rear foot inverted and internally rotated position of the foot. And we know that that has a substantial influence on the torque or moment created around the subtalar joint axis. So, sure. If they're already in an inverted position, an internally rotated position of the foot, it increases the external inversion torque, and hence it's easier to sprain, or, you're at an increased risk of spraining if that's the characteristic feature of your landing mechanism. And we might talk about that a little bit later on when we go on to talk about rehabilitation and things from a sensory motor perspective and a motor control perspective that we can utilize to try and reduce that positioning. We'll also talk about that if we discuss bracing and taping. Sure. Whereas if we flip over to the syndesmotic injuries, we've looked at this in rugby union, and we actually have an abstract that we've submitted for the 7th International Ankle Symposium, which is taking place in University of North Carolina this coming September. And the characteristic feature we see in rugby union is that the player who sustains the injury is actually tackled by two players. So there's an inability to roll out of the tackle position. And the characteristic kinematic profile of the lower limb is that there's a fixed externally rotated position of the foot. There tends to be valgus collapse and forced valgus collapse of the knee and forced dorsiflexion at the ankle joint. So typically someone being blocked or held up from the front and then maybe tackled from the side, contact made around the foot or ankle, holding that ankle and foot in place, valgus collapse and forced dorsiflexion at the ankle joint. And that's a characteristic feature that we've seen in quite a number of these injuries.
Sure. Well, no, thanks for covering that, because it is important for us to recognise, even if we're not party to the mechanism of injury, either on a video replay or watching that live, which of course none of us can see all the details, but to understand these things and get a full description, which is I'm sure something we'll talk about when we talk about assessment in a second, but it's a super important thing. And there are key differences there, different force variables being asked of different people in different sports, super important to cover, so thanks for that. Now it brings us on to, well, before I talk about some underlying predispositions that I think would be useful, just because screening is always an important thing that needs to be touched on at least. But before I do, how does this prevalence and mechanism map onto the general population then? How does that then look with regards, because it's not just athletes. I mean, job logs can trip over a curb and these things can be problematic, and we'll talk about some of the difficulties that they can have that are sometimes different to an athletic population later on in the podcast. But how does that map onto the bigger data?
Yeah, when we look at the epidemiological data of lateral ankle sprains, we see that it is the most prevalent musculoskeletal lower limb injury in the general population, and that confers a substantial health burden, because there's consultation fees as a result of going to the ED, there's days lost through work, there's days lost through school. So basically the economic burden is quite substantial. And we do talk about that in our position statement. We've undertaken a prospective study of first-time ankle sprainers that presented to the emergency department. We have a university-affiliated hospital here in UCD, and this was part of Calvert Doherty's PhD. So we recruited people with a first ever ankle sprain and followed them up, or assessed them within 2 weeks of injury, followed them up at 6 months, and then at 1 year post injury. And we found some interesting stuff. But just to summarize that, yes, lateral ankle sprains in particular are probably are the most prevalent injury or lower limb musculoskeletal injury in the general population. So as you rightly point out, that can be someone, walking across cobblestones. It could be someone hiking on or trail running, or it could be someone going over on high heel shoes.
For sure, no, that makes sense, and we'll probably come to how the difficulties that they face that are different in a little while. But are there any, when I mention screening, for example, I mean it's a bit of a dirty word sometimes, but are there any predisposing factors or variables that we can keep an eye out for in healthy athletes or in patients that are being discharged for or being even treated for other ailments or injuries that we might be doing? And then, are there any certain lookouts that we have, either clinically, radiologically, just certain genetic variables? I'm all ears. Are there any sort of gems that you have in that direction at the moment?
I guess the obvious one is establishing previous history of ankle joint injury. So we know that the primary risk factor for ankle sprain is a history of ankle sprain to the ipsilateral ankle. And we know that in the 12-month time frame following acute lateral ankle sprain, there's around a twofold increased risk of re-injury. So establishing previous history of ankle joint injury is extremely important. Also, the issue of ankle sprain to the contralateral ankle should also be considered, as we know that peripheral joint injury is likely to result in sensory motor adaptations, which may increase the risk of injury to the contralateral side. So, for example, following injury to the right ankle joint, there's published evidence to support central sensory motor adaptations, which manifest, for example, as decreased postural balance on the non-injured side. So actually, a peripheral musculoskeletal injury perhaps confers an increased risk of injury on the contralateral side. And that probably holds true of most lower limb injuries. In terms of, screening, one of the other things that I think is quite important to utilize is specific constructs and specific questions within patient-reported outcome measure scores.
Sorry to interrupt. I've just got to, I know what I'm like, and I know I'll forget my follow-up here, and I think it might be important just to linger on that point with regards to previous injury, because, of course, an important and obvious one. However, there's a couple of things with regards to the laterality thing that you were mentioning. How much, in your opinion, although I know that there's a mix of both, or I assume so anyway, is to do with sort of the sensory motor changes that can occur from a contralateral injury, and how much is maybe then a predisposition architecturally, or the nature of someone's mechanics that might predispose them to that, and then it might get automatically inferred that is to do with the contralateral side, whereas it just happened that they were predisposed and then they've had another event. Do you see what I mean by that?
Yeah, absolutely. So if we take a ligament, we know that it has mechanical properties and we know that it has sensory properties. So I guess from a mechanical perspective, the main function of ligaments is really to guide joint movement through the normal expected physiological range of motion at that joint. And we know that some people are hypermobile. So if there's a degree of hypermobility, that's, I guess, what you are getting at in terms of sort of that's an intrinsic risk factor for the development of injury. And, it probably won't be able to, can't change that. So that's sort of an anatomical consideration. And who knows whether that was in situ prior to injury or not on the contralateral side. But we certainly know that ligaments, they have sensory properties. So they have projections to the gamma muscle spindle system. We know that there's projections to ascending pathways, and hence, overall governance of joint stability can be influenced by injury on the contralateral side. But it is an important point that you do raise, but there is an increasing body of literature suggesting that these ascending and descending pathways are implicated in injury.
Right. Okay. So yeah. So to probably over summarize or oversimplify a little bit is that you would probably lean towards it being a more top down sort of regulation predisposition than it being something structurally predisposed. Is that a fair enough sort of probably oversimplification, but
yes,
kind of what you mean? And then a second one really is, I get a little bit torn on this because I've probably only met a couple of patients in my career that haven't had an ankle sprain before. So, because it's just one of those things that we all, at least if we go far enough back, especially when we say clumsy preteens, it's just almost like you're dragging your feet and you're bound to go over on your ankles at some point. So, is that not an extraneous variable that's hard to account for when you're screening someone and you're thinking, oh, here we go, this is a recurrent ankle sprain, or when really they're just telling a story of life that most would have? You know, how far back do you go, and what specific details might we parse out to know about the relevance of previous injury?
Yeah, it's a good point, and certainly in the prospective study that I mentioned earlier on, our exclusion criteria actually was that they, could have had no history of ankle sprain, our previous ankle sprain, and in that situation, we probably had to turn down 3 in 4 participants.
Yeah, I bet.
So it took us 2 years to recruit 80 participants.
Wow.
In terms of our inclusion criteria, they had to be over 18 years of age as well. So it is quite unique to get a cohort of first-time ankle sprainers. And
Absolutely.
If we look at some of the published literature, there isn't a lot out there on people with first ever ankle joint sprain. And I think our study was actually the first to evaluate sensory motor properties from a prospective perspective in people with first ever ankle sprain.
Mm-hmm.
When we think about rehabilitation and patients presenting to us with a lateral ankle sprain, I think the key component to consider is what type of rehabilitation that they have been through, and really, does that rehabilitation reflect the range of sensory motor deficits that we are likely to encounter? And my guess would be no. Rehabilitation probably isn't as comprehensive as it should be. So there are likely to be lingering deficits there 6 months, a year, 18 months, 2 years following last ankle sprain.
Absolutely. No, that's a great point. I suppose now that we've got your work to lean on, if we're recognizing variables that are in keeping with your descriptions in your research, then we might therefore be in a position to say these are relevant features of a previous injury. So I suppose as ever, the conversation moves forward and the guesswork gets narrowed. So that's a really, really good point and a useful one. So to move forward then, and we can probably point towards what we'd already mentioned, differentiating on the mechanisms of injury, which I think will be probably an obvious place to start. But if a patient presents with ankle pain, let's narrow it slightly and say someone presents with lateral ankle pain. What is the gold standard assessment then from the top?
Okay, perfect. So obviously we think about, the classic subjective and objective examination. From a subjective perspective, the main things that I would be interested in would be mechanism of injury, because that's going to point us in the direction of the likely structures to be injured. So for example, let's take a soccer player. There's maybe a malicious tackle. Contact is made on the inner border of the tibia, just above the medial malleolus, and the ankle joint is forced into an inverted position. That's obviously a completely different mechanism of injury to a tennis player who's involved in a base court rally with lots of lateral movement, and during that lateral movement turns over on the outside of the ankle. So in the former situation of the soccer player, obviously we would be thinking it is a contact mechanism of injury, perhaps a more severe mechanism of injury, and we'd want to think about incorporating assessment for bony injury, and we'd also want to be including in our assessment some evaluation of the syndesmosis, as well as, the integrity of the lateral ligament complex. Whereas in the tennis injury, perhaps we might be more directed towards anterior talofibular ligament or calcaneofibular ligament, and may be placing less emphasis on the evaluation of the syndesmosis or bony injury in that type of situation. The other thing that I think is important to establish is the severity of the injury. And in order to do that, perhaps we could use something like the FAM, activities of daily living scale, so the functional or foot and ankle ability measure, activities of daily living subscale, or the FAM sports subscale, to try and determine what are the impairments that the patient is presenting with. We know that those PROMs or patient-reported outcome measures, we know that they're responsive and we know that they're discriminative. So when we're taking someone through our rehabilitation, we can determine whether they are improving in an objective manner and based on their subjective reporting as well. And then from an objective perspective...
Oh, sorry, just to pull the brakes a little bit, just hover subjectively if you don't mind. Although I agree, what you've said is it'd be the key variables. But are there any sort of telltales for, let's say someone's cranked over into an inversion injury, and we're dealing with something lateral ankle sprain rise rather than high ankle. And are there any sort of telltales with how that would behave with regards to timing of swelling, or let's argue a diurnal pattern, or specifics of weight-bearing status? Are there anything else we can pass out from the literature that would give us clues? I'd be hoping that majority of our listeners would recognise these things from the ones that you've mentioned, but are there any other clues there that could tell us more about either the diagnostic but also the severity?
Actually, not that I'm aware of.
No, is it too varied? Is that?
Yeah, when we look at the literature in terms of, there's a large degree of heterogeneity. So, we haven't got any substantial literature to guide us, from a subjective perspective, and the correlation between subjective examination findings or reportings or observations, and how that ties in with anatomical deficits or anatomical pathologies.
That's really interesting to hear. I suppose that what I'm probably leaning my question towards is this notion. There's a bit of a trend sometimes in the pitch side community of this wise owl recognition of a pattern of bruising or a pattern of swelling, or the idea in which a pseudo X-ray vision can be formed by a pitch side therapist. I've never been able to necessarily find any value to that, either anecdotally, clinically, but also in the research. Is my skepticism playing out in the research, in your opinion?
Yeah, it would be, actually, and I suppose in terms of assessing the ligamentous structures around the ankle joint, we know that actually delayed examination has a higher sensitivity.
Fantastic. Yeah, well, so, that drags you brilliantly into objective then, I suppose, doesn't it? Is that how much should that delay then be? And obviously then please do have the floor to discuss objectives as you were going to.
Yeah, so I'll just outline the objective things that I would tend to concentrate on, and then we can discuss each of them in a little more perhaps. So the emphasis that I would place on our integral components of my clinical assessment would include an assessment of the mechanical laxity of the ligaments. Then I think it's important also to consider arthrokinematic deficits. So perhaps deficits in accessory movement at the talocrural joint or inferior tibiofibular joint, tying in with the Mulligan concept of hypermobility at those joints. I also think it's integral to assess static and dynamic postural balance. I think it's also important to include some level of assessment of muscle strength. So whether that be including hip joint strength, ankle joint strength, maybe can we assess the intrinsic foot musculature, because there's some data suggesting that though the intrinsic muscles in the foot undergo atrophy following a lateral ankle sprain and in persons with chronic ankle instability. And then I think it's important to assess motor control during the performance of dynamic tasks. So maybe I could just flip back there to your initial question on the mechanical laxity. So there was a study published by some authors from the Netherlands looking at the sensitivity and specificity of delayed examination for the anterior talofibular ligament. And what they found was that if the examination is delayed for 4 to 6 days, it optimizes sensitivity and specificity. What they found was that the anterior drawer test is the most sensitive test, and it has higher sensitivity than specificity, meaning that if we perform an anterior drawer test and we don't see a positive sulcus sign, we can be fairly certain that there's no complete rupture of the anterior talofibular ligament. And again, just tying back to what you talked about, pitch side diagnosis, we know, or we can presume on the pitch, if we have the mechanism of injury, if we're seeing swelling patterns develop when the player is taken off, if there's associated bruising, that can guide us generally in towards the structures that we are dealing with. But in terms of making a definitive diagnosis of complete rupture, we probably can't do that until that recommendation from the paper 4 to 6 days after injury, unless there's imaging undertaken.
Absolutely. No, that makes a lot of sense. Now, just when you've just described the objective assessment process, I wouldn't disagree with any of it at all. I suppose just to try and be a bit more detailed, if we can, on that, because they were still within broad categories, weren't they, with regards to assessing strength, assessing static and dynamic balance, and you're describing a palpation and special test, shall we say, assessment more specifically. But with regards to, let's start with then resisted strength, would that be reasonable to do as just an isometric resisted in different parts of range of different lower limb muscle groups, or just movements, shall we say? Or is that something that would be, if we're talking about what the gold standard would be, to refer to my main question, would that have to then involve the involvement of dynamometers and the like?
I believe so, in terms of adding a level of objectivity to it and then using that objectivity to guide rehabilitation progress. I think it's important to always try and use objective measures, measures that are valid, reliable, discriminative, and responsive effectively. So I don't think that manual muscle testing without some instrumentation can offer those criteria.
Sure. Yeah, it'd have to be like an overt weakness or indicative of some sort of discrepancy, wouldn't it? So yeah, that makes sense. And as the technology is becoming more and more affordable, isn't it? So fewer and fewer excuses for us to get hold of those pieces of kit.
Yeah, exactly. Like, so, I don't know what handheld dynamometer might cost £1,000 or something like that. So, probably not that prohibitive.
Yeah, I haven't looked into the market for a little while actually, and I probably will do. I'll do that and summarise this podcast with it, because I think that'd be useful for the listeners to know, and see if there's any that we might be able to get our listeners a deal on. So I'll look into that. But just to then go on to static and dynamic balance assessment and then functional assessment, completely agree, of course, but do you have any particular go-to things that you'd want to test, or would it be very specific to the problem that the athlete is describing or the sport that they do?
Yeah, so again, I would use an assessment of static and dynamic postural stability. So the static postural stability evaluation that I would tend to use, and I'd also use this as part of rehabilitation process, would be something like the balance error scoring system. Right. Now, we know that there are a number of different components to that. So you have Double leg stance, feet together, hands on the hips, eyes closed. It was a 20-second trial, and there are evaluation criteria to make a judgment on someone's proficiency in that position. Then they go into tandem stance, again, eyes closed, hands on the hips, 20-second trial. And then they progress to single limb stance on the injured limb, hands on hips, eyes closed, and there's associated evaluation criteria. Then the second level of that is where there's manipulation of what we would call the environmental constraints. So bring in an unstable surface. So typically the same assessments are performed on an RX cushion. And again, 20 seconds of static postural stability, eyes closed, hands on the hips, and there are evaluation criteria in terms of how many errors the patient makes during that 20-second trial. So again, if we think about the objectification of these measures, there are some good data there to show that it is reliable. It's a valid measure of static postural stability. It can discriminate between groups. So in this instance, it can discriminate between people with and without chronic ankle instability, or people with and without an acute ankle sprain. We know that it is responsive. So if someone is put through a rehabilitation process, we can objectively see improvements on that particular test. So that would be my assessment of static postural stability. In terms of dynamic postural stability, personally, I would tend to use the Star Excursion Balance Test, really because there's the most published or most volume of publications around that from a dynamic postural stability perspective. Again, we know that it's valid, it's reliable, it has discriminative capacity, and it is responsive. So it can be used as an initial assessment criterion, and it can also be used as a determinant of how someone's postural stability, dynamic postural stability, is improving. And actually, Philip Gribble from University of Kentucky published a nice paper a few years ago, I think it was 2012 or 2014, regarding how to undertake an assessment using the Star Excursion Balance Test. And typically he advocates using the anterior reach direction, posterior medial reach direction, and posterior lateral reach direction. And the biggest mistake that people make is that they actually don't normalize the patient's test result to their leg length. So for example, I reach 60 centimeters in the anterior direction, but I'm only 5'10", and someone else reaches 60 centimeters in the anterior reach direction, but they're 6'2". So obviously the test result would be different in that scenario.
Absolutely,
so that's a common situation that is made.
For sure. And with regard, I mean, the Star Excursion Balance Test, I think we'll probably come back to when we start to discuss some of the rehab and treatment variables as well, but a particularly useful go-to test because of the amount of comparable data as well that's now out there for helping people to understand the benchmarks that we can all strive to or look towards, both on assessment and treatment. So definitely well worth pointing people in that direction. And again, key papers in that direction will be made available to the listeners in our Google Drive page. So,
and just one thing also. Cool. Actually performing the Star Excursion Balance Test and the Y Balance Test, which, as we know, is a commercial product based on the construct of the SEBT. They're two different tests, and they shouldn't be used interchangeably. And we have published some data suggesting that the distances that people achieve in the various reach directions and the kinematic profile during performance of the similar reach directions are actually different.
Right, that's interesting.
Kind of choose one or the other and stick with it.
I see, because they often can be misused in either like they can use interchangeably, or sometimes they'll be used in conjunction. and easily get confused between the two. So that's a really interesting point. And so, would you really recommend that people would just stick to the simplicity and accessibility of the SEBT?
Well, it doesn't cost much in terms of all it costs is a few tapes, which you can get from a haberdashery or something like that on 3 tapes on the ground, and yeah, it's easy to use.
Yeah, I think that it'd be a smart move. But like anything, if there's a product, and if I suppose it's not a gimmick, I think that's harsh, isn't it? But definitely there's a way in which things can be commercialized, then sometimes that can be the case. But just keeping it simple is a smart move in that way.
It's just to be aware that actually when someone is performing, let's say, the anterior reach on the ground with some tapes, you get a different reach distance than you would, and an associated difference in kinematic profile compared to, placing your foot on the reach indicator and sliding it forward.
Yeah, pushing the block. Really interesting point for sure. And I think that the listeners will be that'll have raised a few eyebrows, because I think I've certainly made that mistake before. Less so recently, just because I've got some. I've got that many people that are so excited when they want to correct me, but certainly historically I've been making those mistakes and taking for granted the what I perceived were innocuous differences were actually very meaningful. So definitely well worth mentioning. Thanks for that. The one of the things I wanted to just come back to, which takes us to the question of imaging, is palpation within that objective assessment. And I mentioned before that we could nod towards your BJSM podcast with Karim Khan that was out recently that talked more in detail about the Ottawa ankle rules. But could you just briefly explain a little bit about what they mean for a palpation assessment and how that might indicate imaging, at least for X-ray, and then we'll talk slightly more about MR and when that might be indicated.
Sure. So we know that there are four bony palpations and then kind of one functional test. So the bony palpations that we need to be aware of or be able to utilize in a clinical perspective would be able to find the distal posterior 6 centimeters of the lateral malleolus, distal posterior 6 centimeters of the medial malleolus, be able to palpate the base of the 5th metatarsal, and then be able to palpate the navicular bone. And then in terms of the functional tests that we're thinking of or that are advocated in the Ottawa ankle rules is assessing whether the weight-bearing status of the patient on presentation to you. So let's take, for example, the situation whereby we palpate the 4 bony points and none of them recreate the patient's known pain or the pain that the patient is complaining of, and the patient can weight bear for more than 4 steps upon presentation to you. In that situation, we know that there's it's very, very unlikely, less than 1% chance that the patient will have a fracture of the ankle or the foot.
Fantastic. So, and then that obviously explained, and some of the numbers in and around that and likelihood ratios are explained in that podcast you did with Karim.
That's right. So we know that around 10% of people who go over on their ankle joint will fracture. And we know that the Ottawa ankle rules have greater sensitivity than specificity. So they're better at ruling out the presence of ankle joint fracture than ruling it in. So when we combine that 10% or what we call a pretest probability with the negative likelihood ratio derived from the sensitivity and specificity, we get a less than 1% chance of ankle joint fracture if, there's no pain on bony palpation and the patient can weight bear for more than 4 steps. That's really the clinical utility of those rules.
Do we have any evidence to suggest that this is being well implemented in A&E departments across, let's say, Britain and Ireland or the Western world? Do we know whether that's the case? Because I've got this sneaking suspicion in minor injury units and A&E departments that if someone's still not going to go away without an X-ray, they'll still have an X-ray. And I don't know if that's just my skeptical eye, but that's my suspicion.
I can only really talk about the study that we were involved with in the emergency department, prospective study that I talked about earlier on, and I know that they were being implemented there.
Sure.
But
we don't have any broader information about what's being done elsewhere and whether the Ottawa rules are being used properly.
That type of audit hasn't been published to my knowledge, but cool. I certainly know when it comes to treatment that the treatment that is being administered or the advice that is being given sort of kind of positions it as it's just an ankle sprain, it's fine. Partial weight bearing, return to full weight bearing as soon as possible, and you will be okay. So that's certainly a deficit that needs to be addressed.
For sure. Yeah, there's a really frustrating, polarizing situation, isn't there, where it's only a sprain gets wheeled out, but then also if it goes too far the other way, and there can be a real vigilance that can be created over an overprotection of a joint that is sometimes inherently healthy to move on. So we don't want either of those. So yeah, as ever, these conversations live in the middle ground. So really, really interesting point. And maybe we can mobilise the listenership to try and help us with that and find out. We can talk about gold standards, but we also want to know how that maps onto reality. So perhaps the listeners can let us know what's going on in their areas, as well as potentially giving us some audit data if they do have it, if they do have access to these departments. It'd be really useful, and we can maybe add to the data that way.
Sure. Yeah.
So to move, just before we move on to treatment, and I do want to get there because there's a lot to discuss, but are there any differential diagnoses that can either masquerade or can linger in and around a lateral ankle sprain that we need to just be mindful of, that might mean that they alter the timeframes or the rehab response or other factors that contribute to that?
Sure. I guess just two that jump immediately to mind in terms of missed diagnoses, and they would be syndesmosis injury and then osteochondral injury. So syndesmosis injury we've kind of touched on previously. There is some good work from the University of Sydney going into the sensitivity and specificity of clinical assessments compared to magnetic resonance imaging diagnosis. And what that group reported on was that palpation of the anterior inferior tib fib ligament was the most sensitive test. And then the squeeze test was the most specific test. So if palpation of the anterior inferior tib fib ligament, which is easy to palpate between the extensor tendons, so between tibialis anterior and extensor digitorum tendons on the dorsum of the foot. If that's positive, then we should combine that with the most specific test. And the most specific test that group evaluated was the squeeze test. And if the two of them are positive, then there's a high likelihood that the anterior inferior tib fib ligament is damaged, and in that situation it would be appropriate to proceed through to MRI examination or indeed arthrogram in consultation with an orthopedic surgeon. And then the other thing that I mentioned was osteochondral injury. So any microfracture or subchondral cyst. And that tends to be persistent deep ankle pain with the presence of persistent swelling in and around the anterolateral aspect of the ankle. And it tends not to respond too well to the traditional exercise-based rehabilitation or conservative rehabilitation initially.
Yeah, and is it that failure to respond that gives the best indication in that direction, or are there other classic signs that might indicate a, say, Taylor-Doan osteochondral lesion, for example?
I guess just two things, and yeah, certainly the failure to respond to what we might think is just an ankle sprain or just ligamentous involvement, But then again, the description of the patient of where the pain is, and it's typically characterized by a deep pain within the ankle joint itself, rather than an anterolateral pain or a pain that's reproduced on palpation of, let's say, the anterior talofibular ligament or the inferior aspect of the calcaneofibular ligament.
Something sorry, do go on.
No, I was just going to say that would be the characteristic feature.
Brilliant. And something I've just realised I forgot to ask was, if we're suspicious of a frank rupture from the assessment we've just done, which has been wonderfully thorough, as we mentioned, gold standard. But is it then MR with a view to reconstruction as a matter of standard without any particular caveat?
I think that's going to be predicated by conversations with the patient and, the level of activity of the patient, in terms of whether we're dealing with just a member of the public who has no substantial physical demands other than, let's say, recreational sport, or whether we're dealing with a high-level athlete who's involved in elite field or court sports, because a certain proportion of people will do well just with functional rehabilitation and then supplemental external support through braces or taping.
So not dissimilar in a sense to the ACL conversation.
Correct.
And now I suppose I've lent towards still scanning those individuals though, because I'd rather know. Yeah. I don't know, that maybe is that me being risk averse, or is that reasonable?
I think it is reasonable, and most people, when they consult with you, they want a definitive diagnosis. So if we undertake our anterior drawer test and we see a positive sulcus sign and the whole ankle translates forward, we can be relatively certain that there's rupture of the anterior talofibular ligament in that instance. But a lot of people will want confirmatory diagnosis, and in that situation, you're talking about MRI to physically say, here's the radiological report. We can see that there's complete rupture of the anterior talofibular ligament, and that totally ties with my clinical assessment.
Sure, and I think as well, part of my reasoning, I'd map this onto the ACL as well, is that I'm sometimes just seeing is there any other sort of collateral damage, not collateral in the ligamentous sense, but any other issues there that might be
articular problems, or
exactly. And also just because then you don't want to end up in this situation where you're given the hard sell, we think you've got a full rupture here, we're going to try conservative management, and then when they start not responding, they sort of perceive that, does that mean I therefore need major reconstructive surgery, when it could well be that there may be a very straightforward arthroscopy to help that on its way, and we would have known that from the off. And so that tends to lean that way, and do find myself getting some imaging for those. So
and things like an associated peroneal tenosynovitis might show up, or something like that as well.
Exactly. I was just going to mention the peronei, and also the neural structures, particularly laterally. They can. Am I right in thinking they can make the process steadier, but still it wouldn't radically change the rehab process if you say had issues with the say synovitis, not a synovitis, sorry, a paratenon issue at the peronei, or irritation of the peroneal nerve from, or some, as long as it wasn't a full palsy, or it wasn't really altering the actual function of that nerve, but a stinger, so to speak.
Yeah, I think your rehabilitation process is not going to be drastically altered by those two situations.
Yeah, just sometimes slows it down, can make it a little bit more sensitive, can't it? But lovely. Let's move forward then to treatment, and there's two sides to it really. I'm interested in the immediate sense then. So once we've cleared for fractures, what's the best practice care in the first few weeks post ankle sprain with regards to, say, swelling management, to tape or not to tape, to brace not to brace? How would it be best managed in, say, the first couple of weeks?
Yeah, so just going back to some of the literature that's out there, we've recently just published a meta-analysis of systematic reviews in this area, looking at treatment and prevention of acute and recurrent ankle sprain, that was published in BJSM in January. And the main recommendations or findings of that systematic review is that there's strong evidence for NSAIDs and early mobilization for pain, swelling, and function following acute ankle joint injury. And there's moderate evidence supporting exercise and manual therapy techniques for improving outcomes for pain, swelling, and function. And then if the primary objective is to prevent recurrent injury or the development of chronic ankle instability, there's strong evidence for exercise therapy and bracing. So maybe we just talk about the swelling issue for a minute. Typically we would think about the application of rest ice compression elevation, and I know that that's been adopted now to police, which is protection, optimal loading, ice compression, and elevation. So there's been relatively few studies evaluating mechanisms of controlling swelling. And, typically from physio school or, as an adolescent and you injured, you'd ice the area. And one of the studies that has been published about 10 years ago by Chris Bleakley and colleagues evaluated two different cryotherapy or icing protocols for acute ankle sprains. It was a randomized controlled trial. It was two groups. One group randomized to standard ice application, and the other group had an intermittent ice application. So for the standard application, it was 20 minutes of continuous ice treatment performed every 2 hours for 72 hours or 3 days following acute injury. And then the intermittent group applied ice for 10 minutes. Ice pack was removed for 10 minutes, and then a further 10 minutes of ice application. So in total, in both situations, ice application was 20 minutes. The intermittent protocol was 10 minutes on, 10 minutes off, 10 minutes on. And they looked at primary outcomes of pain, function, and swelling. And the only difference that they noticed between the two groups was in terms of a favorable outcome for function in the first week after injury for the intermittent group. And after that, there was no differences in function, pain, or swelling over the course of a 4 to 6 week follow-up. So there isn't any substantial evidence to support the use of cryotherapy applications other than an initial, perhaps, analgesic effect.
Yeah, and a lot of the mechanistic research has suggested some of the age-old thoughts with regards to vasoconstriction and the like have been somewhat debunked. Is that reasonable to say?
I would agree. Yeah, absolutely. Yeah.
And so in that sense, one of the times where ankles have come up on the Physio Matters podcast is about 12 months ago or so, was with Professor Sallie Lamb with regards to what does optimal loading mean? Should we cast them for a few days? Does optimal load mean to what weight bearing can be tolerated? What's your position on that then?
Yeah, so I think an initial period of protecting the ligament is important. And again, when we look at the literature, we see that there are better outcomes with initial support in terms of external bracing or external taping when compared to cast immobilization for a period of days. So effectively what we're doing is we're protecting the ligament, we're allowing a certain amount of loading through the ligament, then that can be supplemented with functional rehabilitation, and that has been shown to produce better outcomes than a period of cast immobilization.
I see.
So kind of links with this police principle of protection, optimal loading, ice compression, and elevation.
So that would be a basic rigid zinc oxide taping, would it? Is that?
Yeah, or a semi-rigid external support.
I see. Yeah. Okay, because I forget the trials acronym, but you'll be aware of the one that I'm meaning with regards to the varying it was cast, tubey grip, fancy brace. That I forget the trials acronym, but that came up with cast was on top of that, particularly on a cost analysis. But you're suggesting that taping or basic splinting has then outperformed a cast since then.
Yes. Yeah, so cast immobilization, where there's non-weight bearing for a period of days, is suboptimal to support or external support in terms of say semi-rigid brace or walker boot. Yeah.
Well, that certainly supports my bias, and my bias was clear as day when we were interviewing Sallie about that, because there is some serious impracticality of having a cast on, and you can't drive in it and things like that. Yeah. So it's certainly I like the noises you're making there, Eamonn, but that's me and my bias. So that sort of covers that initial stages. Then we've got a degree of protection, optimal load, ice if you need the analgesia, but don't pretend that it's squeezing the swelling out of there like we used to. Right. Appropriate analgesia, I assume you would advise?
Yeah, absolutely. So I wouldn't be adverse to administration of pain medication.
But then you mentioned, say, manual therapies. Then would that just fall under the category, in your opinion, of said analgesia, or whatever makes it feel pleasant, or do you feel there's something more to the manual therapies at that stage than just that?
Yeah, so from manual therapy, means different things to different people. So, for example, it could mean massage around the area. So we have mechanical inputs, and maybe through the pain gating mechanism, stimulation of different afferent fibers and dampening down through the C pain fiber system. Or it could include some joint mobilizations when appropriate. So I think definitely both need to be considered. And if we're undertaking a comprehensive evaluation following acute lateral ankle sprain from an arthrokinematic perspective from manual therapy, I think we need to think about the positioning of the talus and also positioning at the inferior tib-fib joint.
Okay, Doc. Right, no problem. And so that's us fairly well covered on the early stages then. As we progress through to a functional rehab process, and I think we can probably, we don't need to patronise our audience in suggesting that we're trying to scale someone from where they are at that point to where they want to get back to, and our gang will understand that. So generally speaking, we can probably press fast forward and then think, what is it particularly during that process that we're measuring and monitoring? So if we walked through step by step there, what would it mean to the key variables that we're keeping an eye on? Is that swelling? Is it power? Is it say the star balance, for example? And is pain a fair metric to guide when someone's ready for each of those sort of next steps?
I think it is, yeah, absolutely. So if we institute something in terms of the rehabilitation pathway and someone has an adverse effect, and that's quantified through a VAS or numeric pain rating scale, well, obviously that's not appropriate for the patient to be doing at that stage. In terms of what we should be monitoring, again, I'd be a big proponent of allowing the subjective and objective findings on clinical assessment really to guide the rehabilitation pathway. A big emphasis for me would be that it's important to utilize, again, objective, valid, reliable, discriminative and responsive clinical assessments. So we allow those to help guide the patient's progress. And they also create patient buy-in, and they allow you to develop a good relationship with your patient. Because if you assess them using the star excursion balance test, for example, and their anterior reach or the posterior lateral reach increases from, let's say, week 1 to week 2 or week 2 to week 3, well, that probably gives the patient some faith in terms of your therapeutic intervention.
Mm. No, that certainly makes sense. Now, when we're scaling people through the process of reloading and exposing them to more variety, I'll admit that I wonder if I'm a little bit traditional on this, where I do stay fairly sagittal in the early stages, keep it simple, make sure that we've got a good balance of range of movement returned, improve strength and capacity and confidence in simple tasks first. Am I being a bit over conservative there, or is there still a fair, reasonable rationale for that?
I think it's fair enough. From our observations, certainly with the cohort that we had of those first-time ankle sprainers, we found a lot of them still 6 months, a year after injury, had difficulty performing a single limb task, eyes closed. So I think oftentimes there is this pressure to expedite someone through rehabilitation, and start to be more dynamic. But one of the things that I tend to utilize is kind of the dynamic systems theory approach to sensory motor control. And that kind of looks at things from the organism, the task, and the environment. So if we think about the organism, and we know that the organismic constraint in this situation is injury to the anterior talofibular ligament. Well, in terms of our rehabilitation, what we can do is we can stress the sensory motor system by changing the task and also changing the environmental constraints. So an example of that would be someone starts off with tandem limb stance, eyes open. We're happy on our balance error scoring system that they meet the requirements of progression. So we then progress them to tandem stance, hands on the hips, eyes closed, and we find that they don't tolerate that. Well, obviously then we need to place an emphasis on that particular construct before we would then manipulate the environmental constraints. So the environmental constraint in that situation might be where we add in an unstable surface. And that's how I'm kind of getting at previously, using objective measures to manipulate the demands on the sensory motor system, whereby we can change the task constraint or we can change the environmental constraint. And I think that's hugely important regarding decisions of returning a person to, training, modified training, or full participation in sport.
Okay, and with regards to the uneven surface discussion, there is, if I just dichotomize it a little bit more than is the case, and say that there's a school of thought that just thinks that Bosu balls and wobble cushions are the thing that's going to cure cancer, and then you've got another side of things that just sees it as being nothing but a gimmick and has no value because it's not got any real relevance. I found myself thinking that if someone's going to be exposing themselves to a variety of different surfaces, particularly your field sport people that will have a more inconsistent surface underneath them than, say, someone on a volleyball court, is it of vital importance that we expose people to different surfaces regardless of what the functional task that they're getting back to is? So where's your position on that spectrum?
Personally, I think it is. The reason for that is what we tend to see following acute ankle sprain is a decreased ability of the person to explore their base of support. So what we tend to see is a freezing up of ankle strategy of postural control and a shift towards a less efficient hip dominant strategy of postural control. So if we think about using unstable surfaces, whether that be an Airex or Bosu, and you actually video what's going on around the ankle, we can see that it those types of tasks are actually demanding that the patients explore their base of support, and they're quite demanding in terms of ankle strategy, of postural control. And I think that's a key link in unfreezing that locked ankle strategy.
Okay, so without that unstable base, they might get into a habit of the cheating strategies that we sometimes see, locking through the ankle and using hip dominant strategies to alter their center of mass. Is that what you mean?
Absolutely, and yeah
okay. I think that's a really smart position. I think that's sensibly balanced. I think that excuse the pun on that one. But I think what I'd wonder is when it comes to timing for when to move people through these stages, and one of those stages, of course, being return to play. We know that these deficits can linger. Yeah. And so we end up with this really awkward threshold where we know that people are naturally going to have a predisposition, partly because of just having had the injury itself. Then we know that they've got a predisposition to a contralateral injury for the reasons we mentioned at the start of the podcast. Then we're sending them back into play with deficits we know take a long time to settle. We're exposing them to not just harm, but also to then immersing themselves back into team sport that involves them training more than just their rehab all of a sudden, because they're getting back into normal play. How do we have a responsibility to be more conservative than we tend to be in ankles rather than other body parts? Should we be being more smart with that?
I think one of the problems is that maybe people aren't being comprehensive in terms of their treatment strategies that they are utilizing. So I think one of the issues that we see is that there's a range of sensory motor deficits. So if we take the classical Hertel model, so Jay Hertel in 2002 published a model of chronic ankle instability where he outlines some mechanical insufficiencies and sensory motor insufficiencies. And from the mechanical perspective, he talks about pathological laxity. He talks about arthrokinematic deficits, synovial changes, and degenerative changes within the joint. So if we want to rehabilitate the ankle from a mechanical perspective, they're the things that we need to consider in terms of our treatment paradigm and our treatment approach. Then we go on to functional insufficiencies. So there's perhaps changes in strength, changes in postural control, changes in proprioception. So the ability of the joint to sense its position in space, the ability of the joint to sense force, and also neuromuscular deficits. So until we start to interact with that full paradigm, I see that as a big problem.
No, I'm with you there. I can't disagree with that. But even when someone is perfectly thorough, and let's imagine this is a patient that you've been had an eye on, and so we know that there's no lack of thoroughness. There's also just a natural bandwidth problem that exists within a human, where even if someone's thorough, there's still a time that needs to pass for the chips to get into line, shall we say? And so even let's say that it has been thorough, do we need to be mindful of the amount of time that's passed? And could you give the listeners any sort of inkling as to, although I know it will be on a case-by-case basis, but what would be a typically too rushed return to play, in your opinion?
Well, there's actually an interesting article published in Journal of Science and Medicine and Sport by Jennifer Medina McKean, and it looked at return to play times following initial ankle sprain and recurrent ankle sprain in collegiate sports or high school sports in the States, and the median return to play time was 7 days, and that was for all ankle sprains. And I think certainly that would be too quick. If we think about the knee and ACL, typically people won't return for 9 or 12 months, and there's even some discussion in the literature around whether people should not be returning to play until 2 years after injury. With the ankle, I think one of the most important things to do in terms of our rehabilitation requirements and our decision process regarding return to sport or return to play is that we need to thoroughly understand the physical requirements of the sports and indeed this position specificity that, and use those as an integral guide regarding our return to play decisions. And I think this is where sports science can make a big contribution to rehabilitation. From GPS-derived locomotion variables can provide us with information regarding total running distance, high-speed running distance, and these can be used as an integral part of rehabilitation programs and return to play readiness decisions. So until a person, can meet the physical requirements necessary for their sport, I don't feel that it's appropriate for them to return to play.
Okay, yeah. I know it was an awkward question in lots of ways because of the individual case-by-case basis that we should assess these things, but I just think the world's in a rush as it is, and particularly the sporting world, the pressures that exist and the culture of it just being a sprain, it's only a sprain, oh great, it's not fractured, I'll be back next week, is such a hard ship to turn around, isn't it? So I do worry that we might be in this perpetual rush for a while longer, but let's hope not. If we talk about then a successful recovery, and someone is back in their, let's say they're back pain free, they've not assumed any chronic instability, how would, say, a team sport player that needs to require regular cutting and agility work manage the issue long term following a full recovery? Say they've had a couple of episodes within a couple of seasons, but then they're fully recovered now as best we can, even on the objective variables that we've been measuring. Should they be doing certain amounts of specific work, or is functional exposure to their tasks and sports enough?
Yeah, okay. I think it's integral to continually stimulate the sensory motor system. So following return to play or return to sport, in most instances, we know rehabilitation stops. And I think that is problematic. And personally, I would advocate, or I would be a proponent of continuing rehabilitation exercises even after return to play and after sport, with the primary objective of trying to reduce the risk of re-injury. So we know from other areas of the body, whether it be knee joint injuries or hamstring injuries, that continual exposure to stimulation of the sensory motor system will reduce our risk of re-injury. So I think the same applies for the ankle. So, for example, supplemental work once or twice per week in terms of strength work, landing mechanics, postural control should be sufficient.
Do you think that in team sports where they're doing plenty of cutting drills anyway, or potentially small box passing drills, say in soccer, would that be sufficient to then? You'd need less specific work because you're getting that element within your training compared to someone that's say not got that atmosphere around them. Even in volleyball, those drills aren't as common, for example.
There's very little literature out there regarding using agility work and cutting as a primary component of rehabilitation programs, and we don't know whether regular exposure to that type of training actually reduces the risk of re-injury. Certainly what we do know from the studies that have been published, two of the key central components that are integral to programs that have been shown to be efficacious for the reduction of recurrent injuries are postural control and our postural balance work and strength training. So regarding cutting and agility work, I can't be certain on that.
So as far as I'm aware, that brings to a close my questions. Have you anything else that you'd like to point our listeners to, or can you be found elsewhere across social media, for example?
Yeah, I'm happy for people to follow me on Twitter if they do so like. It's at Eamonn Delahunt, and I'd be more than happy to interact with any of the listeners and And if anybody has any specific questions, they can email me. It's eamon.delahunt@ucd.ie, and I'd be delighted to open up a conversation.
Fantastic. And what we're trying to do, particularly if we get episodes that kick up a load of questions and comments on social media, is we might start to engage some of our guests, both recent and past, into some Q&As, either on live streams or on Twitter. So keep an eye out for that, and perhaps we'll have Eamonn back on the show sometime soon, maybe across on Facebook Live. So thank you once again for your time. It's been an incredibly informative chat, and I'm sure the listeners have got an awful lot from it. And we'll any of the key papers we've discussed today we'll make available to our listeners through the Google Drive page, particularly our patrons who support us and keep this ticking over. So thank you so much, and all the best for the future.
Thanks, Jack.
So there we have session 40. Massive thanks, of course, to Eamonn, and especially for his time as ever. We really appreciate it, and I feel like we covered some brilliant ground there. I always think it's quite a messy swamp, really, to wade through, between the neglect that comes from suggesting it's only a sprain, but also then the overprotectiveness that comes from, especially in sport, you see people that have habitually strapped their ankle, or have someone strap their ankle for the majority of their playing careers, and I just think that there's such a important middle ground to find there, that I hope we talk through sensibly. If you feel there's any gaps, or you feel there's anything you'd like clarifying, then of course find us on social media. But also, if you think that there's something that we could probably just there's questions that got unanswered, and I probably could have asked or delved a little deeper, then please let us know, and we can try and get see if we can, Eamonn can spare us another 5 minutes, and we can just jump onto our live streams. That's the sort of thing that we're going to try and do over onto Facebook and also YouTube, to do little clips just to tidy up a few things. Some of your feedback from previous episodes has been just wanting us to clarify a few bits. We're going to be able to get our guests back on to do those sorts of pieces, patch up jobs, shall we say, or to re-clarify certain topics that were covered years gone by. As you heard on the episode, I'd really value your time if you would give us some feedback on what goes on in your emergency departments, minor injury units or sports fields, or what happens in your physio departments with the majority of your colleagues. What is going on the clinical front line with regards to acute ankle injuries or ankle instabilities? It's really important that we've been doing this quite a while now, so episode 40, it's really important that we sort of understand, is the tide turning? Is there a sensible middle ground being the majority, or is it still that there's a lot of dismissive attitudes or overcautious attitudes even that are going on in departments, particularly emergency departments or physio departments across the world? So we really want to hear from you, so please, if you could take the time to give us some feedback on that, and especially if you have any audit data that you can share with us that we can then share far and wide, then we'd really appreciate that. Bit of a final update on the newsletter. We're going to get back on top of these things, but a lot of the extras that we'd normally give out on our newsletter, if you signed up on the Choose Health website, you might have seen we're a bit quieter, or it's a bit more sluggish update in the Google Drive page. The reason is that a lot of that stuff goes through onto Patreon, and we focus our attention on extra content onto our patrons. So you've got a couple of options. You can either be patient, and we will be sorting that out soon. Your other option is you throw us a couple of quid on a monthly basis and jump on Patreon. We would also massively appreciate that. But also we seem to be entertaining our patrons fairly well. They seem fairly a happy bunch, so we must be doing something right. So please do consider joining us there and throwing us a few quid so we can keep making our content as we're doing, and spreading our word as widely as we can to try and win what we consider the battle of ideas. So that's enough from me. I hope you've enjoyed this episode, and I'll be seeing you next month for more Physio Matters. And also then, as we've said, we are upping our content on all angles, especially on Facebook and Twitter. So please do follow us at TPM Podcast, at choose_health, and the Physio Matters Podcast, and the Physio Matters Student Focus Group on Facebook. So for now, you've been listening to the Physio Matters Podcast, discussing physio matters because physio matters. Bye for now.